Hello everyone. Welcome to the third webinar of the series organized by Srilanka College of Pediatrics and Childhood Respiratory Disease Study Circle of Sri Lanka. And there are two speakers tonight. And our special guest speaker is Dr. Anne Chang from Australia. And she'll be talking about Pediatric Bronchiectasis, a wake-up call. And the second speaker is Dr. Anuradha from Sri Lanka. And she will give an overview of bronchiectasis in Sri Lanka and in the neighboring countries. Before I start the session, let me convey some housekeeping messages. From now on, you can start sending your questions to the chat facility, which comes on your bottom of your screen. Please do not use the Q&A button. And once the both presentations are over, the speakers will be answering the questions. Let me now first introduce the first speaker, Dr. Anuradha. Anuradha is a budding pediatric pulmonologist in Sri Lanka. She is currently working as an acting consultant pulmonologist at Ledwidge Hospital for Children. And she is also a lecturer at Faculty of Medicine, University of Colombo. Although she is very young to this specialty, she has already done a lot of work on non-CF bronchiectasis and home oxygen therapy. So let me now invite Anuradha to take us through her presentation. Over to you, Anuradha.
Thank you, madam, for your kind word of introduction. Hope you all can hear me. So let me share my content. Okay. Thank you very much, Professor Guani, for your kind word of introduction. Good evening, and let me welcome you all again for this webinar on pediatric bronchiectasis. So you are going to receive a wake-up call from a person who is most suitable to give you this wake-up call, from Prof. Anne B Chang. So I think my role today is just to convince you all whether we should really wake up when it comes to pediatric bronchiectasis. So let's move on. Professor Anne B Chang. I know Prof. Guani is going to give a nice introduction on her, but I still thought that I should share her picture and the titles of this charming lady. Actually, she's a world authority in pediatric bronchiectasis, and I can state with confidence that I have not read a single article on pediatric bronchiectasis where a few of her articles were not cited. So I think she has done a lot of work on pediatric bronchiectasis. So this slide shows you some of her articles on pediatric bronchiectasis. Actually, over the last 3 decades, she has done a lot of work. I think nearly 400 publications on pediatric bronchiectasis. So these are some of her work, and you can see she says pediatric bronchiectasis is no longer an orphan disease. So let's move on and see. So is pediatric bronchiectasis a burden? Yes, it is a burden. Non-CF bronchiectasis is more common than CF bronchiectasis in both developing and affluent countries. It's still common in both areas. And non-CF bronchiectasis is a major cause of morbidity in developing countries and some indigenous groups of affluent countries. But it is said that the overall incidence in developed countries has declined over decades, maybe due to improved sanitation and the control of tuberculosis, measles, and some infectious diseases, etc. But main characteristics of bronchiectasis are yet said to be similar in developing countries and affluent countries. But look at this. Underlying etiology, nutritional status, frequency of exacerbations, and severity of the disease are still different between these two countries. And delay in diagnosis is surprisingly similar in the affluent countries and developing countries. So I think Prof. Chan would explain us why. And these are some of the local studies done in pediatric bronchiectasis. We, of course, do not have a lot of studies in pediatric bronchiectasis in Sri Lanka. We have a lot of studies on adults, but not in pediatrics. So my talk will be based on these two studies, the figures I have extracted from these two studies. And these are 3 descriptive studies. First one I have already mentioned, a study done in Sri Lanka. And the second study is again a descriptive study in pediatric bronchiectasis, which was done under the supervision of Prof. Kabra in India, which was published in Indian Pediatrics in 2015. And the third one is a systematic review done with 989 subjects with non-CF bronchiectasis. This study was done in actually mostly West, and in this review, they have considered the studies done in 9 countries, UK, mainly West, and developed countries, UK, USA, Netherlands, and New Zealand, so likewise. So let's see as it goes the figures of these 3 studies. So let's look at the baseline characteristics. So look at our study in Sri Lanka. So we have evaluated 52 children who have presented to a tertiary center, which is a literature hospital for children in Sri Lanka, with non-CF bronchiectasis, and the male to female ratio was 21 to 31 with female preponderance, whereas it has been opposite in India, and their sample of 80-50 are males. And mean age at evaluation is surprisingly similar. In Sri Lanka, it was 9.45 years, and in India, it's 9.6 years. And the mean age at diagnosis, you can see our sample, we have evaluated them when their mean age was 9.45, whereas their bronchiectasis was diagnosed when they were 5.9 years. That was the mean age. And see the mean delay in diagnosis, 3.8 years. So this delay was from the point where recurrent respiratory tract infections were documented and the HRCT diagnosis was made. So there had been 3.8 plus or minus 8 years delay diagnosis. And BMI standard deviation, mean BMI standard deviation of our sample was minus 0.76. So that is between median to minus 1 SD. And of course, the standard deviation was 1.81. So you can assume that a considerable number of patients have been close to minus 3 SD. And India, they have given it as a percentage. So 76% of patients of their sample, these 80 non-CF bronchiectasis patients, have had failure to thrive. And see the baseline for FEV1, FVC. So those were around 60. So they had been moderately compromised at the time of evaluation. So look at this etiology. So I have mentioned before, the etiology of non-CF bronchiectasis is different from 2 ends of the world. So the developing and the developed countries. So look at our data. Sri Lanka, the commonest reason for non-CF bronchiectasis, the commonest etiology has been post-infectious, where the percentage is 38%. And India, it was 23%. And in the systematic review with 989 children from West, their post-infectious bronchiectasis percentage had been 19%. And then see this, cause not identified. So roughly 30% of the samples, there had not been an identifiable cause for non-CF bronchiectasis. In Sri Lanka, it's 20%, India 36%, and in the systematic review, it's 34%. And then the second commonest cause for bronchiectasis had been primary immune deficiencies. In Sri Lanka, it's 11%, and India is 6.25%, and in West, the percentage is a little higher, it's 17%. So the other etiologies for non-CF bronchiectasis were suspected primary ciliary dyskinesia. Just concentrate on this. Actually, in Sri Lanka, I think we have our threshold for suspecting PCD maybe a little high because we have had only 4 patients. We of course do not have diagnostic facilities, and in India it had been 12. And in the systematic review, 9% of children out of 989 has had suspected PCD. And allergic bronchopulmonary aspergillosis, structural malformations, and repeated aspirations are other etiologies of non-CF bronchiectasis. So when did we suspect bronchiectasis in Sri Lanka? So this is an interesting table. See, 30, that is 57% of our study population, the reason for performing HRCT scan had been persistent head cough or recurrent respiratory tract infections with or without a history of complicated pneumonia. So that is the commonest reason for us to perform HRCT to diagnose non-CF bronchiectasis in our study sample. So other than that, hemoptysis, there have been only 2 patients presented with bronchiectasis, hemoptysis out of these 52. And first episode of poorly resolving pneumonia, there had been 4 patients. And recurrent respiratory tract infections in the background of primary immune deficiencies, there had been 6. Here, of course, we have had a very low threshold of performing HRCT because bronchiectasis is non-CF bronchiectasis is common in children with primary immune deficiencies. And recurrent respiratory tract infections with evidence of aspiration, we have had 3 patients. So these are the etiologies, so these are the reasons for performing HRCT. So was there a delay in diagnosis? This is the most important question, which is actually extensively addressed in most of the published articles on non-CF bronchiectasis, whether there's a delay in diagnosis. I think I would say yes and yes. So mean duration from documented persistent cough, this is documented. So when you look at their clinic records, there had been documented persistent cough or recurrent respiratory tract infections for 3.8 plus or minus 1.8 years before we actually perform the HRCT. I think that's a significant delay. So look at the other study that I have given. This is a study done in Tunisia. So they have also, found somewhat similar rate, similar figure, 2.7 years plus or minus 1.7 years delay in arriving at diagnosis from the point of documenting recurrent respiratory tract infections. Look at the second one. This is very interesting. 41 children out of our 52 non-CF bronchiectasis patients, where the percentage is 78%, were managed as asthma with inhaled corticosteroids and salbutamol for the diagnosis. Actually, when we evaluated these patients, the probability of asthma, according to the GINA criteria, the probability of asthma was low actually according to, in these 41 children who were managed as asthma. So I think the message is that whenever your patients are not responding for asthma, when they are on long-term inhaled corticosteroids or salbutamol with poor response, we do have to think of other causes like non-CF bronchiectasis. And the third point is, HRCT was planned during the first presentation to a tertiary center in 27 patients, that is 51%. So 51% of them, when they presented to the tertiary center for the first time, we have been able to suspect bronchiectasis for us to request an HRCT. So that's an interesting thing. And unfortunately, 8 of our patients, that is 15%, has had missed chest X-ray features of bronchiectasis. So came with X-rays. They came with X-rays. When you look at X-rays carefully, there were features of non-CF features of bronchiectasis in these patients. So those are definitely tell us that there had been a delay in diagnosis. And only 10 of the study sample, 19%, were clinic referrals with the suspicion of bronchiectasis, and all the others were suspected during an admission due to an exacerbation. So that is also an important thing. So there had been less referrals from primary care physicians or the peripheral clinicians suspecting bronchiectasis when they were well. Actually, most of them, when they got admitted with an exacerbation, when we reviewed the history, we have suspected bronchiectasis and done diagnostic investigation. So, last thing, let's look at the complications of non-CF bronchiectasis in our sample. So chronic bacterial colonization had been there in 6 patients out of these 52, and moderate to severe restrictive lung disease had been there in 12 patients, and chronic hypoxemia and home oxygen dependency was seen in 4 patients, and pulmonary hypertension, 8 out of 52. I think India, the reported pulmonary hypertension is less actually. So they have evaluated 80 patients, and their number of pulmonary hypertension patients with pulmonary hypertension had been 3, and pulmonary hemorrhage 3 out of 52 in our patients, but in India it had been 13. So there are slight differences, so depending on the cohort of patients. And the failure to thrive, actually 59% of our patients had failure to thrive, whereas it had been 76, a little higher percentage in India. So these are some of the HRCT findings. You can see some varicose and cystic bronchiectasis of our patients. So most of these patients were actually presented late and had late stage of bronchiectasis, and some of them are oxygen dependent. So key concerns at local setup. I'm not going to actually give inferences on the figures that I have presented because Prof. Chang is awaiting to elaborate on bronchiectasis extensively. So I think the key concerns at local setup is that there's a delay in diagnosis, and there are lack of diagnostic facilities, especially for primary ciliary dyskinesia, and there is poor adherence to airway clearance techniques, and there's delayed optimum medical attention for exacerbations, and poor nutrition, of course, is a concern. So with this, let me sum up my presentation, and the take-home message that I want to give you all is that non-CF bronchiectasis is not rare. It is actually seen in Sri Lanka, and I think actually most of you all, if you all are working in primary care setups, in peripheries, whenever a patient presents with persistent wet cough or recurrent respiratory infections, I think it's very important for you all to evaluate if the patient is on treatment for asthma, and then to refer to a tertiary center. So thank you very much. So I think it's time for us to receive the wake-up call from Prof. Chang. Thank you very much.
Thank you, Anuradha. Thank you, Anuradha. Let me now introduce Professor Anne Chang. I presume Anuradha has given the best introduction that can be given to academic, I suppose. Anyway, Professor Chang is a senior staff specialist at Queensland Children's Hospital, and she is the head of Child Health Division, Menzies School for Health Research, and also adjunct professor, Queensland University of Technology, Brisbane, Australia. And she's a great clinician and a world-renowned researcher, and she's well known for her evidence-based medicine for clinical practice. She is, of course, the person responsible for changing the paradigm of management of pediatric cough. She is the first person who described protracted bacterial bronchitis, which helps to make early diagnosis of bronchiectasis. She's of course, I think she's a person who thinks outside the box, and that's how the diagnosis of protracted bacterial bronchitis came into life. And this diagnosis even went into guidelines all over the world, including UK and USA. And she has, as Anuradha said, published more than 500 articles, and that per se shows her caliber. So in a nutshell, she's a giant in the world of respiratory medicine. And we are very fortunate to have you here today. Of course, virtually, Professor Anne Chang, over to you.
Thanks very much, Professor Guwani, for the very kind invitation, and congratulations, Dr. Kodipoli, for a great presentation. It's an honor to present to the Sri Lankan doctors. I've got a very good Sri Lankan friend, and I work very closely with her, so I've got an inkling towards Sri Lanka. So let me share my screen. Okay, so I think the first thing to say is that we tend not to call non-CF bronchiectasis as non-CF bronchiectasis anymore. We actually call it bronchiectasis because, as what Dr. Kodipoli said, there are more children with bronchiectasis unrelated to CF than to CF. So just drop non-CF throughout your discussions with your patients, okay? So these are a few slides from a study that we did with the New Zealand group. You can see pretty severe bronchiectasis in very young children, 9 months and 10 months old. I'm glad we don't see a lot of these in Australia now, because we have probably woken up to the call, but it definitely still happens around the world. So the importance is not just in children, but it's adults as well. So these are two pretty old studies, but there are not very many studies like this, where they looked at the age of the adults and then looked at the distribution and when they develop their symptoms. And if you draw the line at childhood, in this Australian study by Paul King and colleagues, 80% had symptoms from childhood. And in this UK study, about 60% had bronchiectasis from childhood. So a lot of bronchiectasis in adults start from childhood, and I'll show you later why it's so important to diagnose early, because we can actually prevent this from progressing. So over the next 40 minutes, I will speak about 5 things. The first thing is clinical recognition, and Dr. Kudipuli gave a really nice talk about what's missing in Sri Lanka. I'll talk about the diagnosis and some of the controversies, a little bit about burden, and then just to touch on pathobiology so that you can understand what are the management targets and the options that we use. So clinical recognition, as you have heard, it's all about cough. So chronic wet cough, chronic productive cough. So if you look at the kids and make sure you follow them up, if the cough does not go away, you should really do a CT scan, and I'll come back to that in a little while as well. But you also got to be cognizant that in some settings, reporting may be underdone a little bit. So I do quite a lot of Aboriginal work, and amongst the Aboriginal population, they tend not to report the cough because for them, their cough is a day-to-day basis, so they normalize their cough. So you just got to be a little bit cognizant about that. So the other symptoms are actually pretty variable. Some patients present with wheeze, that's what you heard. Failure to thrive. Hemoptysis is actually quite rare unless it's severe. They can also have exertional dyspnea, lethargy, clinical digital clubbing, and you sometimes hear crepitations. But most of the time, at least in early bronchiectasis, they actually don't have these other features at all, and all they have is a chronic wet cough or a chronic productive cough. So these are some of the pictures. You can see digital clubbing here, and this is an Aboriginal child again who, when I saw for the first time, had very severe hyperinflation here. Someone said it looked like a breast, but it's actually a child who's got terrible Harrison sulci and the pectus carinatum. So this is a slide from Gabriel Mcculloch's work where they looked at the prevalence of symptoms, and again you can see that cough is commonly reported, but in some settings, so this is New Zealand, Jacob Twis's study, only 40% had a cough. So it does vary a bit, just to highlight the fact that cough is variable, and these are some of the other features. So the key thing is that the absence of these features do not mean that they do not have bronchiectasis. Okay, so you look for them, but its absence does not mean anything. The thing that I really want to highlight is spirometry, because when I first practiced clinical medicine, they said that if your spirometry is normal, you don't have lung disease, and we know now that it's utter rubbish, and I'll show you why. So this is the FEV1 and FVC predicted of these studies, and again you can see there's a wide variation, mainly in the 60s, but nowadays most of our children actually have normal lung function. So spirometry and CT scans. So this is a study by Julie Marchand, who was a resident with us. It's pretty old, but this is actually the very first study that looked at CT scans and spirometry, and this is actually in children with CF. Because at that time, we were told that if you have CF and you got normal lung function, you don't actually have bronchiectasis. But so we went on to look at this study. So on the x-axis is a BALA score, which is a graded score of severity of bronchiectasis, and on the y-axis is your lung function. And you can see that these people all have bronchiectasis, and from here onwards, if you take FEV1 percentage predicted as 80% as normal, all these people actually do have normal lung function. So then people started to appreciate that lung function that is normal does not mean that you don't have bronchiectasis. So I still hear people, especially my adult colleagues, who would say that if you have normal lung function, you do not have bronchiectasis, and we know now that that's not true at all. So this is just to illustrate that. So this is a 4-year-old child who had a chronic wet cough. The child's bronchoalveolar lavage grew hemophilus, which is very typical. The cellularity showed a slight increase in neutrophil, and you can see bronchiectasis here on the left lower lobe. And this child, being young, couldn't really do spirometry properly, so we did FOT, And you can see that the resistance values and the conductance values in this child is entirely normal. So even in using FOT, it's actually entirely normal. And this is over the years, and you can see that it's pretty stable, but it remains normal as well. And this is the child when she could finally do spirometry, and you can see here that the FEV1 and FVC predicted are also entirely normal. So showing you that spirometry is normal in this case. So is there a relationship between FEV1 or lung function and the BALA score? The answer is yes, only if the CT scan is severe. So this is another study that we did. Again, I apologize, it's old, but there are actually not very many studies. So I'm really glad that Dr. Guyani and the colleagues are doing stuff on the bronchiectasis. So you can see here that we looked at CT scans using cerebral scoring systems, and the FEV1 predicted correlation with the scales are all very, very low, in fact, and they were non-significant whatsoever. If you look at the New Zealand study, they actually reported a significant correlation, p-values low, and much higher R values. But if you look at their BALA scores, their BALA score was very, very high, whereas our BALA score was actually very low. So even though the population is very similar, i.e. similar numbers, the actual severity of CT scans was very different, such that we had no correlation, whereas they had correlation. So basically, the message here is that in children with mild bronchiectasis, the spirometry is within population norms and does not correlate with CT scans, whereas if the bronchiectasis is more severe, you generally get obstructive airway changes on your spirometry, followed by mixed, and then it does correlate with CT scores. In adults, spirometry is actually a prognostic factor for hospitalization and mortality, which is really not surprising. So what happens with spirometry over time? So this is a study again by Jacob Twist in New Zealand. It's actually the first study that looked at bronchiectasis over time, and you can see here that in children with bronchiectasis it declines, in children with CF also it declines. But the key thing here is that the children with bronchiectasis in the earlier years in New Zealand were also diagnosed pretty late, such that their FEV1s was actually lower than the children with cystic fibrosis. Now the New Zealand has actually done a lot of education, and their FEV1 values at first diagnosis is actually increased substantially, and they've brought their median age of diagnosis down to about 3 to 4, which is where we are compared to what Dr. Kodipoli showed, which is 9 years of age. So this is Andy Bush's study, published a few years later, where again he looked at the FEV1, but the key difference is that the children actually improved after treatment. So whereas the New Zealand study showed that it declined, the British study showed that it actually improved, and the older the children were at referral, the poorer the lung function. Okay, so you can actually improve these children's lung function. So this is our study in Brisbane, and again we actually showed that the lung function can be divided into two groups. Those that were really bad actually do improve with time as well. And again, we showed that there was no decline over the 3 to 5 year mark. So if these children get treated aggressively and optimally, they actually do not decline in the lung function. So for every 1 year of delayed diagnosis, the lung function actually dropped by 1.6%. Again, highlighting what Dr. Kodipoli said about the importance of earlier diagnosis. The other thing we found that there was no difference in terms of lung function change over with etiology or with gender. Now, etiology is really important, i.e., even if you have immunodeficiency and you treat them really aggressively for their bronchiectasis and your immunodeficient, you can actually preserve their lung function. The only thing that predicted decline was actually severe exacerbations, where each hospital exacerbation led to a 1.95% decline in FEV1. So what about diagnosis? So we hammered so far on the fact that you should diagnose these kids early. So in the old days, people older than me would have diagnosed bronchiectasis by histopathology. I'm pretty old, so when I started doing respiratory medicine, we were still doing bronchograms in Royal Children's in Melbourne. But obviously, we didn't do it for bronchiectasis, but we did it for other things. But that's the old gold standard. Now, chest X-rays are very, very insensitive. Depending on what study you pick up, its sensitivity is as poor as only as 20% or even 0%. Okay. Bronchoscopy is not diagnostic. It only provides supportive diagnosis. So the gold standard currently is HRCT scan or its equivalent. That is, nowadays we actually use volumetric scans with HRCT reconstruct. Okay. The key thing is that when do these HRCT changes occur? So this is a child that was sent to me for chronic red cough. The cough didn't go away after a few weeks of treatment with antibiotics, and therefore I did a CT scan, and you can see that this child actually has dilated airways. Okay, if you use the adult criteria of 1.0 of diameter of the airway to the adjacent vessel, this child does not fulfill the criteria of bronchiectasis. But if you use the current bronchiectasis criteria for children, the child does fill the criteria. So it's interesting that I've shown this slide around the world. Respiratory pulmonologists would always say that this child is bronchiectasis, whereas the other specialties would say no. And in fact, this child actually turned out to have CDID, so a type of immunodeficiency. So the limitations of using CT scan is that it's actually in its historical context. And it was first described compared to bronchology in adults. And therefore, not surprisingly, it produces quite a lot of false negative results depending on what criteria you actually use. So the criteria that I mentioned, the 1.0, is called the bronchial arterial ratio, and that's actually influenced by age. As you get older, your skin changes, your hair goes white. So in the lung, you also have changes in the connective elements of your lung. So it's not surprising that it actually changes with age. And as I mentioned, you have different types of CT scan. And when you do a CT scan, when the child is unwell versus doing a CT scan after they've been treated, you actually get different findings. So you just need to appreciate the limitations of the CT scan as well. So nowadays, we actually look at CT scan changes with the clinical diagnosis. So this is a slide from the Japanese group, which looked at age over the x-axis and bronchial arterial ratio, as I mentioned, the key criteria, over the y-axis. So these are adults who are entirely well from a cardiopulmonary perspective. So they've got no cardiac disease and they've got no pulmonary disease. And see what happens as you grow older. It increases, right? So if you take a cutoff of 1, when you're 80 years of age, it's going to be very different if you actually extrapolate this to when you are 10 years of age, or when you are even younger. So to me, taking the adult cutoff is really quite silly. And in fact, for something that's pretty gross, the R values, the correlation between bronchial arterial ratio to age was very, very strong at 0.7. So if you backtrack this line to a childhood age, you actually get a value of 0.7. So what did we do? So this is Nitin Kapoor, who did his PhD with me. We looked at what criteria should be used. Again, I apologize for self-referencing here. The problem is because there's actually no other pediatric studies of this nature. So we took children who predominantly had their CT scans done for oncology reasons, so they did not have any cardiac review. We measured their BE ratio, and 2 independent people measured that. So what did we find? We found that the mean ratio was actually 0.63. And if you take the mean plus 2 standard deviation, the upper limit is pretty close to that deviation, that the extrapolation of that line that I showed you. So we actually suggest that the new cutoff should be 0.8 in children. There's no other studies that have repeated this, so this is a study that needs to be done. And I hope whoever does the next study will also find a similar cutoff, because it only makes biological sense that we should be using a lower cutoff in children, especially in the context of the prognosis of bronchiectasis in children. So as I mentioned, the CT scans are not the same. Nowadays, we do multi-detector CT scans or volumetric scans, and we do HRCT reconstructs. If you take just pure HCT scans as opposed to MDCT scans, you will actually miss quite a few bronchiectatic lobes as well. And these are a couple of slides from this paper that has shown it. You get quite a lot of false negatives. In fact, in this particular study, they found 40 extra lobes with bronchiectasis that was not identified on conventional CT scans. So what most of us do is we actually don't even look at the report. We actually look at the CT scans ourselves, because a lot of the pediatric radiologists don't even know that we should be using a lower cutoff. So you have to educate your radiology department. Okay. So what should you do in clinical practice? Obviously, you need to take the clinical context. You're not going to do a CT scan in children who do not have clinical bronchiectasis as well. You really should take a lower cutoff, because the quality of life improves with treatment. The parents will really thank you very much. And the key thing is you will prevent ongoing morbidity and future irreversible bronchiectasis, which I will show you in a little while. Okay. I cannot show you everything, but there's also really good evidence that delayed treatment is associated with lung function decline. We also know that children who are at risk of developing bronchiectasis can have normal lung function if they are diagnosed early and treated appropriately, such as those with immune deficiency. So that's why we should be very cognizant about the symptoms of bronchiectasis and prevent severe bronchiectasis from happening. So Dr. Kodipoli already showed you some about the burdens. I'll do this very quickly. So, bronchiectasis does still kill children. I'm sorry, this is a little bit old, but this is a study in England, published 10 years ago now. And you can see mortality in young children here. Okay, so kids still die from bronchiectasis. This is the New Zealand study. Again, I just wanted to show you the inequity between cystic fibrosis and bronchiectasis unrelated to CF. You can see in this study here, you get no deaths in children with cystic fibrosis until they are 15, whereas you actually see deaths in the young age group. And that CT scan that I showed you earlier on in the talk showed how severe these kids had. So I'm pleased to say that they've made a big difference now, and they've picked up the bronchiectasis a lot earlier now in New Zealand. So this is Central Australian data, which is predominantly Aboriginal children Aboriginal adults who actually died early. And you can see here, I won't go through everything, 23% of these cohorts in Central Australia was less than 30 years of age, and 13% died within 12 years. So, they do die early as well. So we know that the bronchiectasis prevalence is increasing. This is the UK data published 4 years ago now, although the increase in prevalence is predominantly in the adult age group. Okay, but there is also prevalence in the younger than 30s, and that's the prevalence that they describe. I don't know about the prevalence in Australia, and I certainly don't know about that in Sri Lanka as well. Okay, but as pointed out before, that's substantially higher than the cystic fibrosis prevalence, and you can see here it's much lower in those with CF. So I mentioned about the quality of life. I probably will skip this because it probably won't influence what you do in terms of this particular in studies that you would be doing, but it just shows that the quality of life of parents of children with bronchiectasis is pretty severe. In fact, it's as severe as those with cardiac disease and diabetes. And that's the same whether it's in Australia or in Turkey. It's associated with poor quality of life. There are other burdens such as depression in their parents, and that's been shown in Malaysia. Again, it was worse in children with bronchiectasis rather than those with cystic fibrosis, showing the inequity. But in Australia, when they are treated properly, we've actually shown that the depression score was actually within normal limits. Okay. We know that the exacerbations is really important because this burden in terms of depression, anxiety, and quality of life is increased during an exacerbation. So prevention of exacerbation is really important, not just because of the association with reduction in FEV1, but also because of the quality of life of the children and their parents. So this is just a slide to show that depression scores, anxiety scores, and stress scores during baseline and in exacerbation, it just goes much higher, which is not surprising. So a very quick overview on pathobiology, and in that I will rush through etiology. I'll talk about the paradigm that Professor Guwani mentioned before. I'll just quickly touch on the microbiology and immunity before I move on to management targets. So this is a slide from James Chalmers' paper in 2018, and it divides adults and children. And also you can see high-income countries and low-income countries, and you can see the difference. But as mentioned, you have a lot of idiopathic and post-infectious, especially in the low-income country groups. But this is just a quick overview of the etiologies that has been reported. So this is a slide from India, published just last year, and in India, as Dr. Kudapalli mentioned, tuberculosis and post-infective is the most common. So if you can prevent this, you are definitely going to help prevent bronchiectasis as well. So I won't go through this, but I found these papers, and there was another quick abstract that was published, which I found I really couldn't find a lot of data on Sri Lanka, but I won't go through this because that's already been presented. So people then argue, if you find so much post-infectious thing, do you really need to go through the test to define the etiology on these kids? So when I started doing Aboriginal work, I was actually heavily criticized for treating Aboriginal children the same as I would treat a non-Aboriginal child. So we then did this study to find out if we go ahead and do the studies that should be done for every child with bronchiectasis, will you actually find abnormality? And the answer is yes. So this is the study that we did, and we actually found that we found immunodeficiency in a substantial number of these kids. In fact, depending on whether you include IgG subclasses, it was about 6% of the kids. So even though children with bronchiectasis where you live are more likely to have post-infectious stuff, you really should still look hard because you actually change their management. Okay, what about the paradigm, and this is the key thing about trying to treat bronchiectasis early. So you know that bronchiectasis is chronic infection, you've got persistent biofilms, inflammation, and immune dysregulation. So this is a bronchoscopy. You can see pus everywhere, and these are some of the pictures. You can see terrible bronchitic changes and malacia there as well. So that's associated with ciliary dysfunction, mucus hypersecretion of all this mucus, and ongoing airway damage. and there's airway remodeling that goes on and on with this cycle. And this is kind of briefed as the Coase-vicious cycle. But before it actually starts, there must be something that precedes it, and the question is it reversible? I want to convince you that it is. So that's a normal bronchi. You then get cylindrical bronchiectasis in the mildest form, okay, which then progresses to varicose bronchiectasis, and when it becomes pretty severe, you get cystic bronchiectasis, okay. So I'll try and convince you that cylindrical bronchiectasis or follicular bronchiectasis is actually reversible. So when it's mild, it can actually be reversed back to having normal bronchial arterial ratios on the CT scan. So if you summarize Coase-vicious cycle here, before the steps that happen, you will get epithelial and endobronchial injury and mucociliary disruption. The step before that surely is some early persistent infection, inflammation, or toxic chemicals or biochemical stuff, and that's often preceded by respiratory infections or other triggers. So in the clinical sense, if you look at the clinical manifestation of increasing severity, this is protracted bacterial bronchitis. This is chronic suppurative lung disease. And lastly, you get radiological bronchiectasis, which in the early stages is reversible, followed by irreversible bronchiectasis. So the old definition of bronchiectasis is irreversible bronchiectasis, but nowadays we call it bronchiectasis, which is reversible or irreversible radiologically. So in this first box, you have predisposing factors. You've got modifiable factors, which is the targets of management, and we now also talk about the treatable traits, which I really won't go through in this talk. Okay, but before you get to this, you can actually prevent that from happening by treating all this a little bit earlier. So the microbiology, whether you take upper airways or lower airways, the most common is actually non-tubercle Haemophilus, followed by strep and Moraxella. You sometimes get staph, and unless the bronchiectasis is severe, Pseudomonas is actually quite uncommon. Obviously, I don't have Sri Lankan data, but we know that viruses is common, especially in the exacerbation phase, but you can also find adenovirus in a stable state. I'll just quickly move on to microbiome and biofilm. Just showing you this is a biofilm data from Luke lab in Seattle, and when we looked at bronchiectasis, protected bronchiectasis, PBB and CF, we actually find that there was a significant difference between the richness of the diversity of the microbiome there. Okay, so there is data out there showing the difference between CF and so I better go back. CF and bronchiectasis, but similarities between BE and PBB. So biofilms is also present, and previously biofilms was only thought to be present in people with Pseudomonas, but this is Robin Marsh, who's a postdoc in Darwin with me, and we found that biofilms occurred in children without Pseudomonas, which is one of the reasons why you need to treat with antibiotics for a prolonged period of time. So it's not just the CF group that you need to do that for. You also need to do it for children with bronchiectasis. I'm just showing you this just to show you why we actually need to treat hard and to treat longer, because when the biofilm is present, you also need to treat a lot longer. And these colorful slides just show the biofilm in the bronchoalveolar lavage fluid that we found. So I obviously cannot go through inflammation and immunity, but if you're interested in reading a summary, this is a paper, state of the art, written by one of my other PhD students called Vikas Goyal. and he will describe those things to you. Okay, so I'll move on now to management targets and options. I obviously can't go through every single thing, so I'm only going to touch on principles. So we talked about the vicious cycle, and these are all the possible target points that you can find. So there are different components that you can actually address. This particular slide shows what's feasible and also what is kind of experimental. Okay, I won't go through everything, but I will just touch on the principles. So the management goals in children with bronchiectasis is really to improve their quality of life and to reduce their morbidity. So you want them to be able to go to school, not to cough so much, not to end up in hospital, etc. Okay. You want to reduce exacerbations. As I mentioned, it is associated with lung function decline, and it's also associated with poor quality of life. And obviously, if the kids can't go to school, the parents can't work as well. You want to prevent development of complications, and those complications are more common in adults, where it's more severe, where you can get sleep disturbance, pulmonary hypertension, secondary melioidosis, and the more severe complications. In children, we also want to preserve their lung function. Number 5, which is to achieve cure in a subset of children. So this 4 and 5 is actually not adult components. And adult components, they kind of do preserve lung function as well. But I think once you're on decline, as what I showed you in Jacob Twisser's study, the lung function does decline because there will be a stage where you can't actually reverse the changes anymore. Okay, but 4 and 5 are very, very important in children, especially 5. So if you've not heard before that bronchiectasis can be reversed, I'll show you some slides after this. So this is a study from Liverpool, and this is actually the first study that has showed it. Although the old studies back in Elaine Field's group back in the 50s and 60s actually talked about reversible bronchiectasis as well, believe it or not. So those people in that era were actually very clued up, but they obviously did not have CT scans because they only came into clinical practice in the 80s. So the discussion of CT scan was back in 1983. But so this is the first study with CT scans showing the reversibility. So 22 children, they had 2 CT scans done and had treatment in between the 2 CT scans. The median CT scan interval was 21 months, so quite a long time. They all had CT scan diagnosis of bronchiectasis or bronchodilation. When they repeated their CT scan, 6 of them had complete resolution of the radiological abnormality, and 8 further improved. Okay, so a substantial number of kids, so 14 of the 22, had substantial improvement or complete resolution. And I can show you that it's true even of CF. It's part of what's preached. So this is a child with CF. You can see bronchiectasis here. The child finally was treated properly, and then the bronchiectasis actually disappeared. But this child had mild bronchiectasis. If you measure this, it probably just makes the adult criteria. But once you get into severe bronchiectasis, it becomes irreversible. So these are pictures of some of my own children. This is a 4-year-old. You can see clear-cut bronchiectasis here. 2 years later, the child is totally asymptomatic. There's still a line here, but there's no longer any bronchiectasis. Okay. This is a 3-year-old child. Again, clear-cut bronchiectasis here, as well as over here. It also fulfills the pediatric criteria over here. 7 years later, completely gone. So I don't actually repeat CT scans in most of my children, but sometimes the parents want them repeated because they want to say, oh, what's happened? And then I repeat it, and you can see that the CT scan shows that it's completely gone, and the child is also clinically free of cough. Even in severe bronchiectasis, it does not actually totally disappear, but it can get substantially better. So this is a 22-month-old child from Papua New Guinea who was fostered out by Australian parents. And this child had TB. This is the child's first CT scan when the child presented to us. and the child was treated, and 3 years later, you can see the cyst obviously still there, but it's substantially better. And in some areas, it's actually totally gone. So you can actually make it better, even though it will not totally disappear. Okay? So the management principles are important. You need to diagnose early, as what's been happened to you, the wake-up call, and you need to look for treatable etiologies because it does make a difference. Okay, if you have immunodeficiency, you will give obviously IVIG. We then need to reduce the infection and inflammation cycle, okay, which is really to treat exacerbations early. So you don't wait until the cough is there for 2 months. You need to treat it early, and you need to treat it for a prolonged period of time. And we normally use at least 10 days of antibiotics. If the cough still does not go away, we sometimes use up to 4 weeks. And if they're still coughing at that point, we actually use intravenous antibiotics. And that's the reason why I showed you the biofilm, because of those things. So that's what I mean by aggressively. So they need to be treated early, and they need to be treated aggressively. As what Dr. Kodipoli said, airway hygiene and clearance is very important. So unlike the gut, where you've got in and out, in the airway, you need to actually cough it out. And I often show the kids, you need to cough, 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 and you need to go, okay? So young kids can actually copy that as well, and you need to get them to try and spit it out. So you need to get chest physiotherapists who are experts. So doctors are not very good. Nurses are not very good. You need to get specially trained chest specialists in your clinic structure who are dedicated to chest physiotherapy, and you get them to teach parents how to actually do physiotherapy on a daily basis. So to reduce the infection inflammation, you also need to introduce as many vaccines as possible. Okay. Obviously, these other things, such as things that contribute attention to nutrition, detect complications early, reduce smoking, reduce any pollutants, exposure to tobacco, as well as to coal and biomass, and promote exercise. And systematic care is very important. So these children should be followed regularly, and in best case scenario, they should receive multidisciplinary care. And obviously education, enhanced self-care, and teaching parents what to look for, how to manage exacerbations, when to present, are all part of systematic care. So where's the evidence that antibiotics make a difference? I'm sorry, this paper is 7 years old now, but this is the first study in children using long-term azithromycin. I won't go through all the details. Basically, we gave half the group azithromycin and half the group placebo. It was a 24-month study, and you can see the number of respiratory exacerbations actually halved. So the incident rate ratio was 0.5%, and you can see a very significant p-value there. When we looked at hospital exacerbations, hospital-free period, it didn't quite reach significance, but it was pretty close at 0.06. And this is actually an Aboriginal-based study, so failure to thrive was quite common, but they actually improved in their weight as well. So the Z score actually improved in the weight with a significant level there. There is, however, a risk, because there is a risk of Mcculloch resistance. And because of that, we also looked at the use of other antibiotics for non-pulmonary infections. We didn't expect this, but we found this. We actually found that they not only reduced their antibiotic use for lung exacerbations, but they also halved the use of antibiotics for other infections. So we were actually quite surprised, but that was what actually we found. So you got to be wary about azithromycin and the effect on the bacteria. But the good thing is that we found that it actually gets better if you stop it, okay? And the predictors of Mcculloch resistance is adherence. So the more adherent you are, the lesser the amount of Mcculloch resistance, and we aim for adherence of more than 70%. So this is one of my last slides. The question is it safe to extrapolate CF data? I sometimes get odd emails from other people around the world, and people have been given our DNAs, which I hope you all don't have in Sri Lanka, because it's an expensive medication that people sometimes use. But this is a study to show that when you use this enzyme that's designed for cystic fibrosis, this particular study in adults actually showed that those who were randomized to RDNAs had a higher exacerbation rate, significantly higher exacerbation rate, and they also had a more rapid pulmonary decline. So everything that you do for CF does not necessarily mean that it also works for children without cystic fibrosis. So in summary, I hope I've shown you that bronchiectasis is actually increasingly recognized. It's actually now quite well known because the adults have done quite a lot of work on it, and the burden is actually quite substantial. There are radiological diagnostic criteria, but you must know its limitation. Okay, so try and educate your pediatric radiologist. I've given you a very brief update on some of the pathobiology. I've highlighted the management principles and some of the evidence. And lastly, the last part was on the limitations of using CF studies. So obviously, this is work over many years, and I've got a lot of collaborators that I need to thank. So thank you.
Thank you, Professor Anne Chang, for that comprehensive account on bronchiectasis. There are many questions lined up, but of course, we don't want to tax you too much. I know that it's late night now in Australia, but we'll try to get few clarifications for some other questions. So I'll start with a few questions, couple of questions on protracted bacterial bronchitis. One question is, a fair percentage of adults with bronchiectasis do not have an etiological diagnosis. In your work on protracted bacterial bronchitis in children, you suggested that some of the cases of adult bronchiectasis without an etiology may be due to poorly managed childhood PBB. Is there more evidence for it now?
That's probably a little bit of a misunderstanding. I think childhood PBB will lead to childhood bronchiectasis, which, if it's treated properly, can reverse in a lot of the cases, but if it's not treated, will progress to adult bronchiectasis. I think what the person meant was that there is adult bronchiectasis and there is adult PBB, which is not really very well recognized. So I think if the adults treat chronic productive cough more aggressively, you may be able to actually reduce the prevalence and the burden of adult bronchiectasis. So childhood PBB lead to childhood bronchiectasis. I'm not saying that childhood PBB will lead to childhood adult bronchiectasis because that's too long a time. If it makes sense, because there is a paradigm. Okay, if you don't treat PBB properly, not everybody will get bronchiectasis. Just like in the days before antibiotics become available, not everybody died of, because otherwise everybody would die of pneumonia. So there is obviously a whole lot of other mechanisms that work. So, but a proportion of children with PBB will develop bronchiectasis if it's not treated properly. And I believe that, I don't have proof, but I believe that adult bronchiectasis can be prevented if they recognize adult PBB. There are 2 papers now on adult PBB, but they're not prospective studies. They've kind of looked at our papers and then talked about, yeah, this is also present in adults. I've certainly treated some of my friends with adult PBB, and it goes away. But I don't have evidence for other than that.
Okay, thank you. And now antibiotics are always a problem when it comes to lower respiratory tract infection. So this question is related to that. there's a great reluctance on the part of even the pediatricians to use proper doses of antibiotics for sufficient duration of time for lower respiratory tract infection. Is that a contributory factor for the development of bronchiectasis?
I believe it is. So you probably know that we've done a study looking at 2 weeks of antibiotics for PBB. If you use shorter period, we haven't done 2 weeks compared to 10 days, compared to 5 days, for example. But the reason why, how we actually got to diagnosis was clinically, that's what we did. When you give short courses, the cough either goes away for 1 day and then comes back, or it doesn't go away at all. So there are pathobiological reasons for that. As I showed you the biofilm, and that's why I wanted to show you that particular slide. So you need to treat at the adequate level. If you don't give them adequate doses, it also enhances development of resistance, as you all know. So adequate level is actually really important, and causes of sufficient duration is also important.
Thank you. And the next question is related to diagnosis. What should be the threshold to perform a HRCT scan or MDCT scan?
I think that's very dependent on your local setting. So Dr. Goyal did a study where we looked at the duration of antibiotics, non-response, and risk of having bronchiectasis, and that's our practice based on that study. So if the children if the children come with a chronic wet cough, so wet cough or productive cough, and we give them antibiotics, we obviously try and take a sputum if we can. In a setting where there's HIV and TB, you obviously got to think of those things as well. But in Australia, those diagnoses are very rare. So we empirically treat them with amoxiclavinic acid, only because of the type of bacteria. So the 3 common bacteria which I mentioned, Haemophilus, Moraxella, and Strep pneumonia, they're all sensitive to amoxiclav. If you use just amoxil, Moraxella often is not sensitive to it. So we use 4 weeks of amoxiclav, and if they don't respond after the 4-week mark, we actually subject them to a CT scan. And in Vikas' study, he found that the odds ratio of finding bronchiectasis under that circumstances versus a child who responded to the antibiotics had the odds ratio adjusted of about 30. So it's very, very high odds ratio. But obviously, I think it'd be great if you all can get your own local data. Doing a prospective study will be very, very good, and seeing whether that sort of paradigm is also suitable for your local data. So that's what we do in Australia, because that's what we found. And around the world, in settings like Australia, that's what a lot of people do as well. But I'm not sure whether it's relevant for your setting, Prof. Guani.
So Anuradha would continue like you do. I think in the future we'll do a lot of work on bronchiectasis, hopefully. Okay. And the next question, now you mentioned that airway hygiene and clearance is important in management of bronchiectasis. So related to that, what is the role of prophylactic antibiotics in the management of bronchiectasis?
Yeah, that's a very good question. So the study that I showed, Trisha Valerie, who's the first author, that was amongst Aboriginal children, we use azithromycin. Everyone's got a different threshold. So I personally use azithromycin if they've had a lot of recurrence, and recurrence defined by severity as well as by frequency. So if they've got more than 3 episodes of exacerbations in a year, I would tend to start them on the azithromycin. Or if they've got severe exacerbations requiring hospitalization. Then the question is how long for? That also depends on the child's age. So if the child is younger, I tend to go for a longer period of time, and that's because, as you know, lung growth is still happening, especially before 2. So if they're younger than 2, I tend to go longer. If they are older, I tend to go shorter. I tend to use at least a 6-month course. And in some of the older children, I would go only over the winter period where they have more likely to get exacerbations. But again, you know, it's going to be different in different settings. I don't know how expensive azithromycin is in Sri Lanka. I got no idea about the resistance there and the effect in your population. So I think it would be important to look at some data on resistance as well, just to make sure that we're not causing problems out there.
Okay. So the next question again on azithromycin. So if we are using azithromycin, what should be the dose of azithromycin as an immunomodulator? What should be the right dose for them?
So in our study that we did, we used 30 milligrams per kilogram per week. That was a weekly dose, and that's because we used DOTS therapy there, because they were Aboriginal kids in remote communities, was not that easy to get adherence. In my local clinic now, I use 10 milligrams per kilogram per dose 3 times a week. So it's still the same. It's 30 milligrams per kilogram per week. Then if the kids get a lot of tummy ache, which they sometimes do, I actually go down to 5 milligrams per kilogram per day, but 6 days a week. So the total dose is still the same, but you can just adjust the frequency based on what the parents are and whether or not you need to do DOTS.
Okay. And a small question from me. There's a notion that use of long-term macrolides is not recommended in the presence of non-tuberculous mycobacteria. Is there any particular reason for that?
Because, with non-tuberculous bacteria, if you have macrolide resistance, it becomes much harder to treat. So, as you know, azithromycin is used for treatment. Okay, but if you use it and you then get NTM, it's actually pretty bad news, because you will then have macrolide resistant NTM. So the recommendation generally is, if you're going to use azithromycin, if you can get sputum, you should just make sure they don't have NTM. However, having said that, it's so rare, like none of our kids have NTM unless they're very, very severe, or if the parents do all sorts of funny things. We've got one single child who's got PCD. The parents just keeps using natural therapy all the time, and half treats the kid, which means the kid's antibiotic doses are all over the place, and one day he gets treatment, and the next day he doesn't get treatment. That's a typical setup for failure of therapy.
And I think we have taxed you enough, but I want to ask you one last question, but there are many, many other questions. Sorry, I don't think we have time to answer all the questions. What is the place for inhaled steroids in bronchiectasis?
There's absolutely no place unless they've got eosinophilic inflammation. So unless they've got concurrent asthma, so obviously you would try and prove it with spirometry or test for hyperresponsiveness, or if the kid's too young, then you would use a clinical response, because if you give steroids in children who don't have asthma component in bronchiectasis, you can actually make things worse. There's no data in children with bronchiectasis, but in adults, it actually has been shown to be associated with increased NTM and also increased TB and poorer prognosis, because increased pneumonia as well, on top of all the other side effects that we know from inhaled corticosteroids, like growth, the cost. So,
okay. But however, yeah, sorry, I didn't mean to disrupt.
No, that's okay. So we're actually now doing the ERS guidelines, European Respiratory Society guidelines on bronchiectasis, and you'll all come out there as well. That you should not use unless there's concurrent data to suggest the presence of eosinophilic inflammation in the area.
However, we don't have many tests available to check eosinophilia, because even exhaled nitric oxide is not widely available in Sri Lanka, and we don't check eosinophilia in lavage samples. So then, I mean, is it like recommended to start, I mean, to the benefit of the doubt for the patient and to start on inhaled steroids?
Yeah, no, I really wouldn't do that. I mean, I think you should treat their bronchiectasis first. And then if they're still wheezing or they're still tachypneic, or you run them and see whether they're wheezing and give them beta-2 agonists, and then if they respond, then you could start inhaled corticosteroids. So you could do it clinically as well, just by using the features that you use for asthma. That's what I would suggest.
Okay. And if we decide to start, what should be the best? Is it steroid alone or the combination inhaler? That's another question actually.
Yeah, I mean, I think if you use combined therapy, I would use the same criteria you would use for asthma. So I mean, even when we do physiotherapy on these children, if you put them on inhaled hypertonic saline or bronchitol, we would definitely give them beta-2 agonists beforehand. But I would only use the combined therapy if they've got the asthma criteria for doing that. So there are adult studies on the inhaled corticosteroids for bronchiectasis, and in the adult studies, if you take out the very biased study, because it wasn't blinded and all that, it shows that there's absolutely no effect. And if you look at the side effects, they actually increase the density of Pseudomonas in those who were given steroids. And there is one single paper on the use of combination medication, but again, that was a very biased study because it was non-blinded. And the paper, when they reported it, was actually quite different to the data that when we analyzed it. So what you find in the Cochrane review is actually quite different to what was published. Oh, excuse me.
Okay. Yeah. Thank you very much. And I think it's time to wind up this session. Thank you, Anne, for your time and expertise, and especially during this unprecedented time, coming virtually and enlightening us. However, I hope you would be able to visit us soon in person, possibly next year or year after.
Okay. Thanks. Thank you so much for the invitation, Prof. Kuwani. Nice to see you.
Hope you will keep free for us in your calendar.
Okay.
Not for us, okay. And thank you, Anuradha, for sharing your experience of bronchiectasis in Sri Lanka and in the region. And I would thank all the attendees who tuned in today. And on behalf of Sri Lanka College of Pediatricians and Sri Lanka, the President Sri Lanka Childhood Respiratory Disease Study Circle, and Dr. Manel Fernando, I should not forget, she's the President Sri Lanka Childhood Respiratory Disease Study Circle, and she's of course the guiding light behind all these endeavors. And thank you so much, everybody. Thank you and good night. Bye.